here for me. So this like clinical scenario is going to be your guy. He's like 40 years old. He's a smoker, and he went out and like playing football with the boys, and he felt or heard like a shotgun, and he can't plantar flex his foot. So you're going to roll over on your stomach for me.
Maybe I should go here.
So this is a Thompson test. What you do, pick them up, squeeze the calf, you should see the foot plantar flex. Okay. So if they have an Achilles tendon rupture, when you squeeze this, their foot's just gonna stay, just like this. Okay. So that's a pretty easy one there.
Whoa.
Yeah, you see that?
It's like magic.
So just squeeze it there. Next test, we'll go into just the regular ankle stuff. So you can go ahead and roll over for me and take your shoe off and your sock as well.
Oh, it's Portia's, yeah. I'll just ask her. She'll send it to you. Maybe she'll post it.
I'm guessing that's what you're doing. Are you sharing it?
So you can scoot down this way for me.
I think that was an idea.
Only
You're
me.
gonna have, like, just your
None of you guys.
So you
That's
can
like.
scoot back just a little bit. Just this one. We'll just do one foot. So scoot back a little bit more. A little bit more. Perfect.
I'm
All
gonna
right.
turn it this way.
So ankle ligaments, most common injury, inversion ankle sprain. Anterior talifib ligament is the most commonly one to be torn. So the talar tilt test is just like what it sounds like. You stabilize the ankle here, so you grab around the tib fib, and then you just pull the ankle in, okay? Just like this. So you test the lateral ligaments here, and then you test the deltoid here. And actually, if you really want to stress the ATF, what you do, you bring them into a little bit of plantar flexion, and then you pull in, okay? And then I think the other ones we have, so you have the drawer testing.
Wait, back to the talar tip. Would that be? Is it pain that would make
Yeah.
you pause?
So what you would find, there would be pain, there'd be laxity too. So like if they did a stress x-ray and you thought you had somebody with a grade 3 ligament sprain, which would be complete tearing of the ligament, you could do a talar tilt, take the x-ray, and then measure your difference between your talus and the fibula. It's a way of kind of grading the ankle. Maybe to say if you thought this person was going to need surgery, if your ankle's a little bit lax, you can actually get it over there. You ever sprained it before? So next will be the ankle drawer testing. This is testing for the same thing. It's going to be laxity and specifically the anterior talifib. So you grasp behind the heel and you want to stabilize on the front of the tibia here. You have to make sure they're loose, and then you have them in maybe, I don't know, 5 degrees of plantar flexion. You just give them a little pull, just like that. All right. And if anybody's ever sprained their ankle before, like you've had a significant sprain, when you pull on this ankle, you'll feel a clunk. All right, and it's a positive test. You'll feel a clunk too because the talus will actually hit the front of the talocrural dome, which is the anterior aspect of the tibia. So kind of smack into it, and they won't be happy either. So you just warn them that it's going to be a little painful if this is actually something positive. You can actually do a posterior drawer test too, but that's not part of the stuff that they taught us.
Those two are on the check sheet.
It might, is the drawer testing and the ankles on there?
Yeah, or I don't know, one or both of those.
The knee.
I think it's just the
first
knee.
one.
It's the
I know
knee.
that,
Yeah.
Everting and inverting.
Yeah,
the
so
ankle.
when you're doing that, it's forefoot inversion, eversion. You're grasping the heel and you're everting and inverting the foot, just like that, okay? Because you don't want the talus to move, you just want the forefoot to, okay? So that's the test for PD lab. The syndesmotic test, so you have a syndesmosis that runs in between the fibula and the tibia. So it kind of works to keep them from spreading, because each time you step down, the talus is forced up into the tibia and the fibula. So you have a tendency for this joint to want to spread if you sprain that ligament, syndesmotic ligament. You have the same thing in between your forearm and the radius ulna. So what you do, you get over here on these malleoli, or maybe just a little higher, you give them a squeeze, and this would be painful. and you probably see some laxity there too. That's what they were showing us when there was an x-ray up. You're looking at A to P of the ankle, and you see your fibula over here, tibia here, they come down, you see the malleoli, and you look in between them. If the fibula, if you measured, and there's a certain criteria for like the distance between them, if it's over that, then you know you have a high ankle sprain.
The pain is coming from the bones rubbing against each other.
Exactly, and if you have someone with a high ankle sprain, they're probably not going to be able to walk on it. We would usually put them in a boot for a few weeks, and they would only come out to do therapy. They're really tough to heal. Sometimes they have to surgically fix them with a screw coming in from the side and basically bring the malleoli back together.
So that was the syndesmotic?
Yeah, that's a syndesmotic.
How is that the same as abduction aversion with dorsiflexion?
Okay, so it's a great question. What you do, it's external rotation. All right, so what you're doing, you're locking the talocrural joint, which is the talus and the tibia, all right? And then you bring them over like this and you spin it. So what I'm trying to do, tib fib right here, trying to open it up like this by spinning the talus inside of them. And you kind of want to have their foot on your forearm, and you really want the motion to be here at the heel, not so much with your arm. Okay, so that's how I'm spinning her foot, external rotation. And you have to have them dorsiflex. If you have them down here, you're not
And you're
gonna,
squeezing with your left hand?
just stabilizing. That's all this hand does. Just stabilize the whole time, just like that. All right.
So basically that's pushing the talus in between the tibia and fibula and using it to pry them apart.
Yeah, it's like a crowbar.
Right, exactly.
Basically,
Okay.
trying to bring them apart. And there's actually, apart from the syndesmotic, there's actually an anterior and posterior tib fig ligament that could tear as well. But that's just for you guys. Molder click test. So with this, what you're gonna do is you're gonna compress the forefoot, and then you're gonna poke and compress in between the metatarsals. All right. So with a neuroma, which you have your nerves, just like in the hand, they run in between the metatarsals. Okay. Well, if I'm wearing my high heels to dinner every night for 40 years, I'm probably going to develop a neuroma here. So you get a thickening of the myelin sheath. And it's really painful. Patients describe it like they have a pebble or something in their shoe they're constantly stepping on. So this test is a way to elicit pain with that. Now, whenever you do this, you don't really want to really squeeze that hard, because if you squeeze together metatarsal heads, you squeeze all their nerves too. So they're going to be like, oh, that's super painful. So you want to stay a little lower, give it a squeeze, and then press. You may feel a click or something like that. I mean, really what you're looking for is pain. And then the other test is basically the same thing without squeezing the metatarsals together. So the web space compression, this is also more commonly referred to as a pencil test, because what the old school people like to do is take a pencil, find that second and third metatarsal space, and you just press it down in there, and it re-elicits the pain. That shouldn't be painful right now, right? Yeah. So that's pretty easy. And then the foot squeeze test is the Molder click without palpation. So you're just squeezing it together. All right. Not too bad. Ooh, knee stuff. All right, so we'll start off with McMurray. This is probably the most sensitive of the tests. You can go ahead and lay on your back here. So this one's easy to get intimidated by. Like you see an orthopedic surgeon do this, and he's taking the knee and he's wiggling it all around, and you don't know what's going on. Probably one of the easiest ways to do it is bring them into deep flexion, which may be painful anyways if they have a meniscus injury, and then you give them some rotation like this. Okay, so you kind of grind it together. What the surgeons are doing is pinching the meniscus. Okay, so when you bring it here, you pinch the lateral meniscus, which is important if you suspect what kind of tear. Cruciate ligament tear. And ACL. ACL is, you typically have lateral meniscus. meniscus.
Oh, he was asking a question.
Yeah, I was asking you guys. And then same thing, you try to pinch the medial meniscus, you come out to the side. Okay, so here, and then here,
No worries.
and deep flexion. Okay. Now, if you want to do it a more simple way, you can roll over on your stomach.
So that was kind of a broad test for both the meniscus and
Yep.
the ACL.
Medial and lateral meniscus. That's my favorite test because when you're doing it, I should have explained it a little better. You have your fingers in the joint line. Okay, so you have it in the medial lateral joint line. You're feeling for tenderness and for clicks. If they have like a bucket handle tear or something, for one, you may not even be able to get them into full flexion, but you might actually feel something under your fingers or elicit pain. So, athletes, you would be standing on the same side as the affected leg, just so you guys can see. So when they're in this position, they shouldn't have any pain. All right, if they do, I axial load the leg here and twist, it'll make it a million times worse. Okay, so if that is painful, you lift up, it should relieve the pain. So that's a positive test. So athletes, push down, give them a nice spin here. You're grabbing the top of the foot. And then at the end, if it's painful, give them some distraction. That's it. Should alleviate the pain. Any questions about?
So the positive is the pain when you initially push down.
Yeah, so pain when you push down and rotate, and then it should be relieved. Pull up. And I think we have another test.
So it's pain when you pull up is positive.
No,
If
no,
it
no.
doesn't relieve.
Should relieve pain when you pull up.
Yeah,
I'm
okay.
sorry if I misspoke. It'll be pain when you push down, 'cause
Yeah.
you're compressing the meniscus, and then it should alleviate the pain when you pull up.
Okay.
Like that. Okay. Let's see. So, Lockman and anterior drawer are the next two. So you can go ahead and roll back over again. So the one we need to do for lab is a Lockman. For these, you have to have your patient lay on their back while you do it, and then it's not going to be common that you get a positive test with these because after somebody tears one of their cruciate ligaments, the hamstring spasm, so it's going to be really difficult to get a positive test, especially with your anterior drawer, because the hamstrings are at a pretty favorable angle to keep the tibia from coming forward. Okay, so we'll start with this one. I like to sit on the foot, because if you sit back here and you pull and their foot slides forward, it doesn't do any good for you. So put them in some flexion. Put your thumbs on the joint line here, the tibia. Get behind, and then you don't really want to jerk, because that's just going to hurt your knee, especially if it was already swollen and you thought they had ACL tear. What you do is you just give them a firm pull like this. Okay. Now, if you watch my thumbs, see how they come towards me? You're looking at the side. If this person had ACL tear, her tibia would come forward. I mean, I don't know, maybe 5 millimeters or something like that. Like you would really be able to tell because your thumbs would come at you. You can feel the tibia sliding forward. Posterior drawer, exact opposite. Same thing, sit on the foot, and then you push. What you would be feeling if it's positive is the femoral condyles coming towards your thumb. You do that. Makes sense? Okay. Lockman's probably the most fun one. So what you do, the key to Lockman is really the hand placement, because if it's your first time doing this, you're like, I don't know what to do, but what you want is to be able to pull tibia forward while stabilizing the femur, or you can even push it back a little bit. All right, so you want them in just a few degrees of flexion, just like this. Wrap your hands around and then pull, push. Okay, that's good.
Yeah.
Now when you do this, I don't know if you guys can get close, like you don't have to be scared or anything. You can see her tibia come forward a little bit. Okay. See it there?
And it's supposed to. So an
It's
abnormal.
supposed to come forward a little
A
bit.
little.
Yep. And when you feel this, you're going to feel a firm endpoint. All right. It says the ACL is going to let you pull maybe like a millimeter or so. If it's torn, there's gonna be gross laxity there, and you'll have like a soft endpoint, and that's what you don't want. That's for sure. All right.
So the difference between Lockman and anterior joints, you're still trying to distract the tibia off of the femur, but it's just the position you have the leg in while you're doing
Yes, yeah, that's exactly right. So instead of having them flexed and where the hamstrings can really
Get
pull
really
and- yeah,
engaged.
and keep the tibia from coming forward. With the Lockman, you have them maybe like 10 degrees of
I'm so
flexion,
excited.
so it's hard for them to spasm and keep you from
Gotcha.
testing this.
Gotcha.
The pivot shift. This is probably like the most difficult test to do, and I'm not going to pretend like I actually know. But you're supposed to keep them totally extended. Put them in internal rotation. What this is supposed to do is make the tibia slide anterior on the femoral condyles if the ACL is torn. Okay, because I believe the anterior medial bundle of the ACL should be keeping tibia from sliding forward. So you load them to put pressure here, internally rotate, and then as you would bring their knee into flexion, you would feel the tibia slip backwards, back into the femoral condyles because the IT band and the hamstrings are pulling it back. So you keep them here, rotate them in, then you bring them up into flexion.
Slide back in with that
Yeah,
last
then
motion.
slide back in. Okay, that's a really difficult one to do. Let's see. Then you have your valgus and bars testing. You guys feel okay with that?
Mhm.
Always test 0 degrees, 30.
It was 0 degrees.
So 0 degrees is just full extension. So you test them here. They may not have laxity here. It's a partial MCL tear because they actually have 3 bundles of the MCL. So if they're stable here, that's great because that means that it's likely not a full thickness tear. If you bring them to about 30 degrees and you pull, it may open completely up because you've torn other bands of the MCL. And then same thing with the LCL. You just have your hands in opposite orientation.
Valgus is stress to the outside. Well,
Valgus, you're stressing a medial ligament.
right.
Varus, you stress a lateral ligament. Something like that. Patella fracture, they just won't be able to do a straight leg raise, most likely. It's pretty painful. The developmental hip dysplasia, I'm not even going to go into that. That's pediatric cases. You bring them up into flexion and you push, and they should sublux posteriorly.
There's also pictures on that.
Yeah, he's got good pictures of that. Log roll, get it ready. This is it. That's log roll. Okay. If they have a positive log roll, is not good. Okay.
differential's not good on that.
Yeah, positive for like septic arthritis, hip fracture, something like that. You can have it with the FAI as well, which is next to the femoral acetabular impingement. This is your like pincer lesion or your cam lesion. So cam would be an enlargement of the femoral head in the acetabulum, or you have a pincer, which would be an enlargement of the rim of the acetabulum that's impinging on the femur. So this one, Fadir, it's a flexion, adduction, internal rotation. All right. So what you're doing, you're kind of blocking the femur in the acetabulum, and then you're grinding it across the top. Okay. So if there's some type of impingement there, this will be really painful. You won't like this at all. So that's it. And then let's see what's next.
Treatise.
Go ahead.
Oh no, I was just
You had a question about it?
No,
Oh,
I'm
okay.
just saying dumb stuff.
No dumb questions.
No.
Finkelstein's, for this word that I can't say that has to do with tenosynovitis, excuse my voice crack, of the extensor pollicus. It's either extensor or abductor. It's this one right here. Okay, so you put the thumb in, grasp it with your fingers, and you just turn it down, just like this. Okay, it's kind of a painful maneuver, anyways. So I don't think it has very good specificity or sensitivity. But you need to know it for the test. Yeah, Finkelstein's. Finkelstein's.
Stretching one.
Wait, is that De Quervain's or Finkelstein's or both?
Finkelstein's is the test for
Deckwork.
Oh, okay, I gotcha.
Yep.
So you'd have pain with that.
Yeah, it'd be painful. It's pretty much painful.
It's painful.
Just to be
Yeah.
good. I mean,
Stretching up that, yeah.
yeah.
Uncomfortable.
I do.
Uncomfortable.
No, you're doing alright. Maybe you're just superpowered.
Next, carpal tunnel. So Tennell's, you're just tapping into the carpal tunnel. You get neuralgia into the first 3 fingers. That's typically how that'll present, but they'll have other symptoms like their hands go numb at night, or they go numb while they're typing, things like that. Phelan's is just an additional way to test. Put your wrist like this, their hands get numb. My hands would probably do the same thing if I left it here for long enough. I'm not sure exactly how long you're supposed to
It's a
leave it.
minute.
It's a minute.
1 minute? Yeah.
Seems like forever.
Foveal sign. So this is the triangular fibrocartilaginous tear. Okay, so it's a disc that sits here on top of the ulna. All right. Now it's kind of like the disc that you have in your TMJ joint. If you know that, there's a small fibrocartilaginous disc there. This disc can be dislodged. So if you went into something like a hyper ulnar deviation, you can pinch the disc, you can tear it. It's pretty painful. They have to surgically repair it. The only time I've seen that is actually in athletes, people that play sports with sticks like hockey, lacrosse, things like that. They will typically present with this. But all you're doing, the foveal sign, is just palpating right here. So you find the ulnar styloid, and you just try to kind of palpate right in there. Is that okay?
And they'll just say ouch.
They'll say ouch. You may have clicks with ulnar deviation, and this will increase the pain for the patient. They won't like that at all. You can think of it like the meniscus of the wrist. CMC osteoarthritis. So this is grandma that likes to knit. I think there's an axial load test. So you stabilize her wrist, and then you're pushing the first metacarpal
Like in?
in. Yeah, you're loading it into the scaphoid, and I think it's trapezium that you're loading it in. And then there's a grind test. All you're doing then, you just grab the thumb and you're rotating it around. If they have
Still pushing inward.
Yep, still pushing in. So you load it and then you push to grind it. And this will be for osteoarthritis. So people that are like hairdressers, because they're constantly doing this, cutting hair, can get arthritis there, or like your elderly people that are knitting, things like that. Distal biceps, the hook test, remember
Yeah.
that one?
Yeah.
You have to make sure that they're supinated, or you won't be able to get it, because the biceps is mainly a pronator of the forearm. Okay, so you go there, you should be able to get your finger underneath of that.
So weird. I don't
It's
like
not a
that
fun
feeling.
feeling. So that would be your Popeye sign there. It'll rupture the tendon, biceps retract up. You can also rupture it the opposite way, from the long head, or I guess you get the short head too, where the tendon ruptures and you get a Popeye that's lower.
So is that
The
reverse?
reverse Popeye.
I think reverse Popeye is lower.
Lower.
The mechanism for this will be an eccentric loading of the forearm. So somebody's doing a curl, they shouldn't be, comes down, and this just snaps right off. And they'll repair that. Rotator cuff, everybody's okay with empty can?
Yeah.
I like this. It's 90 degrees in a scapular plane. Okay, so don't have them all the way out the side. It's really all you're doing then is activating the deltoid. You're gonna bring them in maybe 30 degrees or so, about right here, load the forearm. So it's supraspinatus. Belly press. This is a really good one for subscapularis. So all you instruct the patient to do is put your hands on your stomach, elbows out the side, and then you push this.
You have the patient push or you push?
Patient pushes.
Patient push.
Patient's activating the subscap. Another way to do this is something called the Gerber lift off, which is what they told us to do for imaging the subscap with ultrasound. But you would actually resist the patient, and then they lift their arm off their back. Okay.
And if they can't do it, that's positive.
It's positive. But you'd really only be able to use that test in like a young athlete. Your elderly population, the people who are commonly going to have full thickness rotator cuff tears, won't be able to get their arm behind their back anyways. So that's why the belly press is so useful. So don't go in the clinic and try and get 70-year-old grandma getting her arm behind her back and lifting off, because she's not going to do it. And it's going to be painful. Horn blowers, teres minor. I believe this is also called resistant throwers by some. So what you do, you get them out here about 90 degrees at the elbow, and then in the scapular plane again. Support the elbow, and then what you're going to do is tell the patient to push back against your hand here. Okay, so you can push, perfect. She's nice and strong, so your teres minor's not torn. It's great. It's good. Everybody get that one? Out to the side, and they push back. So it's similar to the Hawkins, which I think is next.
Do they just push back with their
They
hand?
just push back with their hand.
Okay.
What you want is the rotation of the humeral head. You don't want them to come back with their elbow, because then they're just activating the posterior deltoid, and that's going to give you a potentially like a false negative for the test. Drop arm. So this, you have to help the patient, bring them out to their side, bring them up, and then you'd say, what I want you to do is slowly lower your arm back to your side. Okay, just nice and slow. So stop about right here. The person has a supraspinatus tear, just let your arm go loose. They're just going to fall straight down to their side like that. Okay, they can't maintain it as they come down.
So they're going to get to that point and then it's just going to drop.
Yeah, they'll get down, maybe they get to 90 degrees, and then it just falls right to their side, and it's commonly painful. So that's another one for rotator cuff pathology.
They're not able to lift it up.
They most likely wouldn't be able to lift it up either, because when you're trying to get them to activate that motion, if they have a supraspinatus tear, if it's pretty fresh, they're probably not going to be able to get their arm up. If it's chronic, usually they'll start compensating with their deltoid, and they'll do this. They'll be like, oh yeah, I can get my arm up my side, and that's not what you want to see. Then we've got near, because of internally rotated, so internally rotate your arm, and then you just bring them up. Okay. Subacromial impingement. If you had pain with this test, that's what it'd be indicating. Not a very sensitive test. Then Hawkins, just have you out the side. Same thing, scapular plane again, support the elbow, and push it in. So here you're pushing the rotator cuff up into the acromion. So if there's impingement there, if there's a spur, if it's like that, whatever, the type 3 acromion, it's going to push down into the supraspinatus, and it won't feel too good. Crossbody adduction. This one, supposed to actually put that under AC sprain there. What you have the patient do is bring your arms to cross, touch the opposite shoulder, and that's if we thought we had an AC sprain here. Now you won't see this in a book, but a good way to test this, if they're not exquisitely painful here, is you tell them to keep their elbow straight, and then you push up, and you push down. This will be really painful if they have AC pathology that maybe you're not seeing the palpation. It's not like a grade 3 AC joint separation. So that's a good test to use. And then it looks like the spine didn't make it onto this one. All right, so spurling. Spurling is for brachial plexus injury. So what you do, you have two different types of brachial plexus injury. You have compression, like this, pinch the nerves, and you have a traction. Okay. So commonly referred to as getting hit in the ear hole in a football game. It whips your head to the side. They get a lot of burning, neuralgia down into the hand, pretty much the whole forearm, arm will be affected with it. So what you do, take the patient, let's say I thought she had a compression injury on this side, I would just flex her head to the side, it would recreate or exacerbate the symptoms. And then if I brought her to the opposite side, then it should alleviate the symptoms. Okay. And then it would be vice versa if it was a traction injury. If it was a traction injury to this side, bring her over, it would be positive, and then the opposite there.
Because you're pulling on it.
Yeah,
Okay.
because it was a traction mechanism, and you just recreated it.
Got it.
Another way to do spurlings, the way that I learned it, is actually for cervical nerve root compression. Is probably the more proper definition for the test. With this one, you'd actually have them, they're going to extend their head just a little bit, they're going to turn to the side, back like this. You apply an axial load to their head. Okay, so if they have some type of nerve root pathology, or if they have a ruptured disc in their neck, or you think they do, when you push down on their spine, it's going to recreate the symptoms there.
But you're turning the head away from the area of suspected injury. Or...
So what you're doing here, you'd actually test both sides.
Gotcha.
What you want to do is close those apophyseal joints. So you rotate, bring it back. So I'm testing the right side right now.
Gotcha.
Okay, just like this, because the joint space is closed, and then you shorten it even more.
Okay.
You should see symptoms in this side, and then vice versa.
Okay.
So thoracic outlet syndrome. This one, the first one is Adson's test. It's what you have them do. So thoracic outlet syndrome is typically a compression of the nerves and the vascular bundles that are crossing underneath the clavicle, near the first rib, and then down into the arm. So what you'll do, bring this arm back into extension. So you put tension on the clavicular area here. You palpate the pulse, okay? She's got a good pulse now. And then you're gonna look back at me. You're gonna bring your chin down to your chest a little. So if someone had thoracic outlet syndrome, the pulse would go away. You wouldn't feel pulse anymore. Because they're compressing that neurovascular bundle. They're between it's typically between the first rib, like the clavicle or maybe the scalene there. To treat it, besides physical therapy, they can actually take the first rib out. Let's see. And then the EAST, the elevated arm stress test. This one's pretty easy. You see it slide, you just put your arms out to the side like this, and you just start opening and closing your hands. Just like that. And you should get a recreation of symptoms into the arms from
How
the.
fast?
I usually tell patients to do it pretty fast and actually squeeze their hands, and then after they've done it for about a minute, you can have them bring their hands back down. And you know, like when you squeeze your hands out, squeeze all the blood out, you can see if there's a difference in the palms when they return to their, like when they're perfused again. Typically the affected side, it'll take it longer to perfuse.
So how long would they have to do
I think it's for 1 minute, or it's like 1 to 3 minutes. It's a long time.
I can't hold
So that's why the other one's probably a little quicker. You can just feel the pulse, have a look at you.
Exactly. If you're in a patient's room and you're in there for 3 minutes watching them do this, I mean, neither of you are
Long,
gonna
awkward
be-
silence.
Exactly, yeah. Okay, so disc herniation. So this one, you get the straight leg raise test. I think you guys remember this one from lab. Just lay on your back. You're gonna bring them up nice and slow with this, and typically you're gonna recreate pain by maybe 30 or 60 degrees of hip flexion. They'll complain of pain shooting down into the leg, commonly into the foot. If you want to really get them going, bring this foot back. So say maybe you get them, you really think they have some type of nerve root pathology, you get them to 60 degrees of flexion, they're not really feeling any pain, put traction or dorsiflexion on the foot, and then likely it'll recreate pain.
So is that regards then?
Yes, that's regards. I don't know why they made them separate.
separate, yeah.
You do them all. And then often, like say we get her up here, and this is painful, if you flex them at the knee, it'll alleviate the pain. So just kind of, it's more diagnostic for the disc pathology. And then of course you can be positive in the opposite leg as well. Things positive across straight leg raise. Regards I already showed you.
Could the straight leg be negative and the foot be
Oh yeah,
positive?
yeah, definitely. And that's what I was saying. When you bring them up, if you get them there and you're like, man, I really think they have something going on with their disc, but they're not having pain, put traction on it, then it'll often retrace the pain. Then. So it's kind of just like stepping up the intensity of the test. Sacroiliac dysfunction. This is the.
Did you do the flip test?
Oh no, I didn't do the flip test. Yeah, flip test. It's the same thing except they're seated. You be seated on the bed. Just bring your foot out. And this is the one he was talking about for your malingering patient that says they have back pain, and then you fake them out. So you're doing a knee evaluation. Bring them out. They don't have pain.
You want me to do it?
Yeah, you can go out. So what you would do, you just passively bring this knee up. That should recreate pain. You can bring the toes back too. There's actually a variation called the slump test. You bring your chin to your chest and you kind of slump your back like you just have really bad posture. Then you bring then I would raise your leg up and you'd have a recreation of pain. That would also be positive for nerve root compression.
So me actively doing this.
I would do it for you.
Oh.
Yeah, you just sit there like this and then I would bring it out. You don't have to know that. That's just a good test to use.
Okay.
Yes, then it's the Faber test. For this one, you just lay on your back, and this is the exact opposite of the deer. So instead of bringing them up, flexion, adduction, internal rotation, flexion, abduction, external rotation. And what I like to do is just leave it, leave the ankle down on their opposite knee, and then you just push down. And what you're doing is compressing the sacroiliac joints. You do that. So one hand here, the other here, give them a push. It'd be painful. You can also have them lay on their side and push down on the joint.
And not just the ipsilateral SI joint, so if it's right leg, it's right SI.
Yes, if that tests the same side joint. You can also do a test where you get on the SI joints here, push opposite directions, and you compress both. That's just another way to do it. And then the Schober's test, we don't actually do this. You have to find the iliac spine or iliac crest. You measure 5 centimeters above, and I think 5 centimeters below. You make lines there, and then you measure the difference between those lines when they're in flexion. And I think it should increase to like 20 centimeters or something. And that could be another one you could use if you thought they had ankylosing spondylitis, which would grossly limit their flexion. I like to think of ankylosing spondylitis as kind of like your body's self-made fusion of the spine. So you have your bodies separated by discs sitting on top of each other, and as you get the ankylosing spondylitis, they start to grow together and fuse. So then when you had your disc space, you can flex forward. When all the lumbar spine are fused together, you're limited in flexion. So that's it.
So a positive test for that one would be a small increase in the distance between the vertebrae.
Less than 20 centimeters.
Less than.
Yep. And that's the only one for the ankylosing spondylitis.
Thank